Hi, guys. I'm Darren Deester. I'm one of the resident faculty here at Spear Education, and I'd like to welcome you to our study club meeting. Here at Spear Education, we all really believe in the power of an approach to patient care that maximizes the interdisciplinary team. By creating and developing an effective interdisciplinary team, we allow each member of the team to really focus on the area of dentistry that they most enjoy, and probably, that's an area of dentistry where they are at their best. And we do this with the expectation of improved outcomes for our patients, especially in complex cases. Treating complex cases with an interdisciplinary approach is not without its own set of challenges, though. So an example of this type of challenge would be, how do we maintain effective communication before the case begins, during the treatment phases, and then even following the completion of a case? Another example of a challenge we could face in interdisciplinary cases is determining the sequencing for a case and maybe even determining any phasing required for a case. And to a degree, these challenges, they may occur simply because we now have more than one clinician participating in the treatment. So really, many of the challenges with interdisciplinary treatment involve the team and how we learn to grow and work together as a team rather than working as a group of high-achieving individuals. And that's one of the real benefits to a study club like the one you're participating in right now. In this module, Dr. Spear addresses another challenge to the interdisciplinary approach. And this is a topic that I think really affects all of the members of the interdisciplinary team. And that topic is, how do we begin to establish and communicate our fees for complex interdisciplinary cases? So we've got a really great module ahead of us. Before we begin, please just take a moment, make sure that you have all the resources that are available for this module. And if you don't have those resources, go ahead and download them now. And then when we come back, Dr. Spear.
Hi, I'm Frank Spear. I want to welcome you to this module. What we're going to talk about in this module, I think, is truly one of the more challenging things we do in dentistry, and that's discuss fees, especially when we're talking about communicating fees with patients. But in this instance, we're going to talk about fees in the interdisciplinary type cases, which becomes even more complicated because now you're talking about potentially 1, 2, 3, 4, or even more clinicians being involved in the process. So just to give you an idea of what our objectives are for this module, what I really want to do is help you become very conscious of what the communication challenges are that exist when we have multiple clinicians treating a patient. I'm going to provide you with a model that my interdisciplinary team has used successfully to communicate with patients surrounding fees for literally 30 years. And in particular, I want to help the restorative dentist look at some key issues to help you maintain your profitability in some of these more complex patients. So, we have some very obvious challenges that come along with this territory. One is that when we start talking about interdisciplinary care, each of the clinicians is going to have to gather their own records. They're going to have to do their own examination. So that alone starts to complicate things. And then the bottom line is we're going to have to come up with a coordinated treatment plan that we can communicate to the patient. And that treatment plan, in some cases, if it involves a young person in implants, it could be years before that treatment plan's completed after growth. And so we're going to talk about, so how do we work fees through all of that? What do we do about talking about fees, et cetera? And then we're also going to have the conversation about who presents fees. And what about over time as a year goes by, 2 years goes by, 3 years goes by, et cetera? What do we do about that? In addition, we have to be real. The fees that we charge for these cases have to provide profitability. If they don't provide profitability for everybody involved, it's going to be difficult for all of us to continue to desire treating these kinds of complex patients. And then finally, the patients, we're going to have to communicate to them in a way that they understand that there's a lot of things that sometimes become transitional procedures, such as, for example, bonding of worn teeth or long-term temporization, that literally they're just done to get the patient to a different stage in treatment at which the next phase can be completed. So I'm going to give you just a few example cases to help us have this conversation, to help you as a study club have your conversation. And we're going to start with really probably the most straightforward of all of them I'm going to show you, and that is a patient who's congenitally missing 6 teeth, both upper lateral incisors, both upper second premolars, both lower second premolars. In the photograph that you're looking at, she's just about 13 years of age. This is what her smile looks like. Obviously, she's going to need orthodontic treatment. There's going to be decisions made about permanent premolars that are missing on the top, the retained primary molars. Here you can see the retained mandibular primary molars. So that's who our patient's going to be. And obviously at age 13, it's going to be a reasonably long road between when she starts orthodontics and when treatment gets completed. And so the kinds of things that I would like to think about in this patient is I know we're going to need ortho to open up space. Ideally, I'd like to replace all those teeth with implants. There's going to have to be some temporization done for potentially 4 to 6 years. Then we're going to have to talk about, so what happens when the implants are placed? Is it immediate temporization? Is it a more delayed approach, et cetera? And then final impressions and ultimately final restorations. What I'd like you to do for your first discussion is here she is at age 13 with her parents. And I guess the question becomes, where do we go with fees? What do we tell the parents of this 13-year-old who's congenitally missing 6 teeth about what the future looks like? How detailed do we get? And I know I have some biases in some of my answers surrounding this, but I'd like you just to stop as a group and literally imagine now this 13-year-old is sitting with you and her parents, and you're going to talk to them about here she is today, and this is what the next how many years looks like concerning fees. When you're done with the discussion, I'll show you how she was treated, and as I said, I'll give you some of my biases about fee discussions. Welcome back. I hope you had an interesting discussion about the details of what we would say and in fact, what kind of numbers we would give her. Because if she's 13 now and she may not get the implants till she's 19 or 20, obviously those numbers could change pretty radically. So I'll just give you a few thoughts from my interdisciplinary team. One of the things that we found for sure was if we didn't give patients some concept of what the numbers were, they tended to be very upset later on. And so even though the numbers will change, we would typically tell patients, if we were doing the treatment today, this is what the fee would be for a single tooth implant, for the surgery, for the restorative on top of it. Ultimately, your daughter might end up with 6 of them. So if it was done today, here's what the cost would be. The reality is the cost will be more in the future because we're not going to be doing any of this for 4 or 5 or 6 plus years. So our bias was always give patients a number. Didn't mean we were going to honor the number. It meant we were going to give them a number so they weren't blindsided when the day came that we actually started talking about implants, et cetera. In the case of this young patient, one of the things you can do about fees in interdisciplinary cases is to try and phase the treatment of the case. And this happens to be a case that's relatively simple to phase. So the first thing we did is the surgeon took out the primary canines, then the orthodontic phase of treatment was done. So now the lateral incisor sites are available, but she's only age 15. So we know we're still too early for implants. What about the premolars? Our bias, and again, my team and I worked for years on these kinds of cases, and our bias was if you had a missing permanent tooth, but the retained primary tooth was there and not ankylosed, we would typically keep them as long as we could. However, the width of them is incorrect, and so it was not uncommon to go ahead and take a burr and narrow down that premolar to the correct width for a permanent premolar, and even bond it with composite so it's the right height. And here's what it looked like after Vince Kokich Sr. then closed the spaces up both on the upper and lower retained primary molars. So in reality now, she only has to replace the lateral incisors. And from a fee perspective, her parents really couldn't do it until she was about 19. And so this is what the radiograph of those primary molars look like. And what are we going to do about the lateral incisor site? Because you've got 3, 4, 5 years before she can do anything. And I guess the other question is who's going to do it, and then how are they going to charge for it? So naturally, the orthodontist typically is going to make some sort of a retainer. And the challenge that we found long-term was a traditional removable retainer had a few risks that went with it. One, obviously, was them not wearing it or losing it. The bigger one is it doesn't hold the canine roots. And so sometimes if we left these cases 3, 4, 5 years, you'd actually see the canine roots tip back in, and they'd have to go back in orthodontically and open them. So more commonly, the restorative dentist, or in this case me, would come up with some sort of fixed retainer where we would bond 030 orthodontic wire, we'd put a composite ponic on it, and that would become our long-term temporary because it keeps the roots torqued. Now, obviously, there's an additional fee. And part of what I want the restorative dentist to realize as we go through this series is in these kinds of cases, there are a lot of what I'll call transitional steps. They're procedures that you do simply because you can't move forward. And those transitional steps have to have a fee associated with them. At the end of the module, I'm just going to give you a few thoughts on maybe how you think about those fees, but definitely recognize these kinds of things. In long-term interdisciplinary care, these kinds of extra steps come in there. Finally, at age 19, she was able to have the implants placed. The surgeon's fees were his current fees at that point in time. My restorative fees were my current fees at that point in time. So we had given her a number when she was 13, but here we are 6 years later, and obviously the number that we'd given her is not remotely like the number 6 years later. But she understood that. At least it gave her a ballpark. Now we've got the lateral incisors done. The question is, well, when do you do the other teeth? And the reality is, for retained primary molars, typically not unless they become mobile. And in her case, it took 2 more years before the upper primary molars became mobile. So now she's at age 21, and she's having the 2 upper premolar implants placed. And again, the fees are the fees for that period of time. So now the lateral incisors are done, the second premolars and the maxilla are done. This photo, she was 34 years of age, so 21 years after starting orthodontics. The lower primary molars are still there. They're still there today. This photo was taken a few years ago. And so in terms of fees and interdisciplinary cases, some of the cases can be phased. And so in cases like this one, it really helps manage the treatment if you can phase the extractions and phase the implant placement. But that's kind of a good example of a pretty clean, straightforward ortho surgical restorative case with implants, and starting from an early age, and then how do you manage it over time? And really the only kind of additional fees in there was those bonded temporaries over that long-term period of time. Now, let's take a different kind of ortho restorative case. We're going to take a patient who has worn and over-erupted incisors. Typically, these cases, again, need a transitional phase. What's the transition? Usually composite bonding. So most of these patients, the orthodontist is going to take usually around 6 months, sometimes a little longer, to try and get the erupted teeth into the correct position. Now the patient's going to have an open bite. It's going to look bad. When they try and eat, food's going to be coming out. And we need to go in with composite and bond those teeth and then put the brackets back on and complete the orthodontics. Now again, the beauty of that is it does allow for an option for phasing. Because once the ortho is all done, the composites are already done. If the patient can't do the porcelain for a period of 1, 2, 3, 4 years, the composites suffice just fine. And so, again, I want the restorative dentist to realize it's a transitional phase, but you do need to charge the patient for it, and the patient needs to be aware of why it's necessary. And then ultimately, at some point in time, in most of these cases, you go to the final ceramic restorations. So here's the patient. Really, it's an issue of upper and lower incisors primarily. And so the upper incisors have wear and have erupted down. The lower incisors are worn and erupted up. I won't go through all the steps. Here is 6 months into orthodontics. Again, Vince Kokich Sr. is the orthodontist. He has proclined and intruded the upper anteriors. He has intruded the lower anteriors. And now he's going to remove the brackets, and it's time for the restorative dentist to do direct bonding on the upper and lower. Now, when I do transitional bonding on any of these cases, it's just one shade of composite. This is not meant to be really fancy and layered and all those things, because in fact, he's going to put the brackets back on. The brackets are just coming off long enough to do the bonding. So kind of to make it more efficient, what I often do is I have the orthodontist the month before, when they take their arch wire out, do an alginate impression so they can send me models of the case, and I'll have a diagnostic wax up done on the upper incisors and lower incisors and I'll grind the brackets off the model so I can actually make a matrix, so it makes it much more efficient to do the composite. But suffice it to say, it's not going to be composite that you would look at and go, oh, that's spectacular, let's leave it on there forever. And so here's the lowers built up with composite. In this case, canine to canine was built up. And here's the patient. At the end of orthodontics, the upper incisors have composite on them, the lower anteriors have composite on them. And the bottom line is, for the restorative dentist, some thoughts on fees. If ultimately this patient's going to transition to ceramic relatively soon, I would typically call all of those composites buildups, because I'm probably not taking all of it off unless I'm doing partial coverage veneers, which in this patient, in fact, is probably what you will be doing. But in a lot of patients, if you're going to be doing any kind of full coverage, it actually functions as a buildup. If you're thinking that this is going to be a restoration for 5 years for this patient, then I would bill it out typically as whatever surfaces it is. So is it a mesial, incisal, distal, facial, lingual, as opposed to the build-up fee. But if it's going to be a short-term, 1, 2 years even, typically I view it as a composite buildup, and we transition it then to the ceramics. In this patient, ultimately they transition to the ceramics, 6 upper anterior veneers, 6 lower anterior veneers. But again, I just want you to see there's these transitional steps in the middle, and there has to be charges put in there. Otherwise, you lose your profitability in the case. So those are, fairly straightforward. But let's now talk about some of the things where maybe we're using some of the newer technology, and I'd like to talk a little bit about, so who does what in cases where maybe we use cone beam? Who does what if we're doing, we're making a guided stent from the cone beam? And so we'll take a relatively clean 2 central incisor case, and I want to talk a bit about fees and a bit about temporization. Do we do an immediate temporary? And if we do an immediate temporary, as in the day of surgery or within a day or 2 of surgery, who makes it? Who charges for it? Obviously, after the temporary is done, there's going to be the final impressions. There are going to be final restorative. I'd like to talk a bit about fees for implant cases in particular. Implant cases, it is so easy to lose profitability for a restorative dentist so fast. So I'm going to share with you why, and I'm going to give you my formula for what I do regarding fees on implant cases. So here's our patient. Very healthy male, but the two central incisors have resorption, and it's now perforated to the palate. So the two central incisors need to be removed, and we're going to place implants. So the discussion I'd like you to talk about is most of the time these patients are seen in the general practitioner's office. And the question becomes, so who does what records on implant cases? What would the surgeon in your group prefer? What would the general practitioners prefer? What radiographs get taken? In this particular patient, they happen to have really good bone. It's going to be a nice, clean implant case. So the question is, do you in fact do guided surgery or not? Do you have a surgical guide made, or do you do it with a more traditional surgical guide? I mean, for years before we had cone beam, we did these cases with very traditional surgical guides that were quite simple to fabricate just out of a clear matrix. And so I think there's a lot of things in the implant world, and it really does come down a lot to who's the surgeon doing it, what would they prefer. But as a study group, because implants are definitely part of what's happening in your group, it's a really helpful conversation to talk about radiography, surgical guides, and temporization to kind of get an idea of, okay, what's the surgeon prefer? What's the restorative dentist prefer? What's the restorative dentist comfortable with? What's the surgeon comfortable with? Some surgeons absolutely aren't comfortable making temporaries. They don't want to do anything other than basically a healing abutment. Other surgeons I know actually make the immediate provisional. And by the time the patient goes back to the dentist, it looks like the tooth's still there because they took tooth out and made the immediate provisional. So go ahead and stop, and as a group, have a discussion about, for your group with the people you work with, how do you manage the implant phase, and particularly the radiographic phase, the surgical guide, and temporization. And when you're done, we'll come back and I'll just walk you through this particular patient and, in fact, how I typically do it with the surgeons I work with. Welcome back. Hopefully you had some good discussion that clarified the roles in your group surrounding things like the radiographs and the surgical guides, et cetera. Let me just share this patient with you and how he was treated. Traditionally, and I've worked a lot with Dr. David Matthews as a surgeon over 30 years, traditionally Dave doesn't like making temporaries. And so we've kind of come to the role where anything basically from tissue coronally is done by me. In this instance, we're going to do this patient as an immediate temporization case. So Dave has removed the teeth, he's done 2 bone-level Straumann fixtures, and he's put on some soft healing abutments simply to hold the tissue out of the way while the patient comes to my office. And that was done in the morning, and the same afternoon I'm going to be making the temporaries for this patient. Now, if the patient wasn't coming to me the same day, interestingly enough, what I'm going to show you next is kind of how we usually proceed. The most common thing that we use for the surgeon, because most of the surgeons that I've worked with really don't like making temporaries very much. Instead, what we do is prior to extraction, we have a very well-fitting pressure-formed base plate. This happens to be a product called 1 millimeter splint biacryl that's really well adapted. And what the surgeon typically would do if they weren't sending them back to me that day is they would extract the teeth, place the implants, and then adjust the roots on the extracted teeth so that when the patient puts the splint biacryl in, the roots basically are just a bit short of touching the healing abutment on the implant. Makes a great way for the surgeon to do their procedures, take the tooth out, put the implant in, put a healing abutment on, and not have to deal with composite or acrylic because they just put the same teeth right back in. Now, in this case, what happens is I already had a model on this patient, and in the lab, we've removed the teeth from the model, and we've drilled a hole through where the roots would have gone. Dave actually has made an index using impression copings with some composite triad. So after he placed the implants, he put the impression copings on them. He molded triad across the adjacent incisal edges, light cured it. And so basically now I put my lab analogs onto that index. They fit on the teeth, on the model, and the analogs hang down into the space where I've ground it away, flow a little stone there, and I instantly now have my model in a matter of minutes that matches the patient. And this is just my preferred way of making temporaries immediately, as opposed to doing it in the mouth. But there's a lot of people prefer doing it in the mouth. Once I get to here, my most common immediate temporary is the extracted teeth. And so I take the extracted teeth with a high-speed diamond and I hollow out the inside of them. I fit some temporary titanium abutments on the implants, and I opaque them with a white opaquer from Kerr called Color Plus. And then I go ahead and etch and paint adhesive inside these teeth, load them up with temporary material, seal off the holes, obviously, where the screws are, seat the biacryl on there, and essentially I now lock the two natural teeth right onto those abutments. Then you just take a diamond and you drill through them to get access to the screws so you can unscrew the whole thing. So here it is with the biacryl holding the teeth. Again, really predictable and simple because it's the right contour, they're the right shape, the emergence profile is correct. And then all you have to do is flow composite between the abutment, temporary abutment, and your natural tooth. And you can see in this case the implants are coming a bit to the facial, not a problem at all. But so you just put your hole to get to the screw access wherever it needs to be to access the chimneys. And now the day of surgery, we can put our two temporaries in place and then cover where the hole came out with composite, and we've got our immediate temporaries. So again, going back to fees. Now, there's the issue of, okay, who did what in this case? So he extracted the teeth and he placed the implants. And then I went through a reasonably, I won't say prolonged, but laborious procedure to make two really nice temporaries. And they're transitional, obviously. We're going to have to go to final impressions, et cetera. But nevertheless, there's got to be a fee for the temporaries that were just made. And then we have our final restorations, again, skipping steps. But you've got, in this case, milled zirconia. You've got Emax over the top. We want it to be beautiful, so we're using a really high-quality lab. And here's the final restorations with the zirconia in place, the crown seated over the top. And just to show you, this is 21 months after treatment. You can see the bones holding really well on the implants and between the implants. Aesthetically, the case works good. So for the restorative dentist, let's talk about fees. So let me tell you why fees on implant cases can get out of control quickly. One is that you can't predict the lab fee because you don't know the angulation of the implant. The other thing is you have a lot of parts to buy. My worst case scenario was in 1994. I had quoted a fee to a patient of $750 for an implant crown on a canine implant before the implant was ever placed. And the implant was placed way to the facial. The lab had to do a custom abutment with a lingual set screw because there wasn't enough length to do a cement retained crown. And the lab fee for me was $700. My fee to the patient was $750. And so it was literally back then that I went, okay, I'm not doing this anymore. So since 1994, I will tell you what I do. You may or may not be comfortable with it. In our office, we have what we call an implant surcharge. It's not a significant number, but implants end up usually costing me more money to treat than if it was a single tooth. So there's an implant surcharge. And, it could be a few $100s, depending on the case, depends how many implants are there. There's going to be a surcharge per each implant. There's a provisional fee. You're going to make temporization to manage the aesthetics in the soft tissue. There has to be a provisional fee. There's going to be, in my office, a parts fee. If I have to buy parts, if I have to buy temporary abutments and I have to buy impression copings, et cetera, whatever I can't reuse, I'm going to charge the patient a parts fee. So there's going to be the temporary abutments I had to buy, for example, or the lab analogs that had to be purchased. Then there's going to be what my normal crown fee would be. And then, frankly, on implant cases, I pass the lab fee along to the patient. So that, and when we quote fees for implant cases, we quote a range up front of what the lab fee can be. I can absolutely tell them what my fee will be for the crown. I can absolutely tell them what my implant surcharge is. I can absolutely tell them what the provisional is, and I can pretty much tell them exactly what the parts fee is. The only thing I can't predict is the lab fee, and that's simply because of implant angulation. And we explain that. So we tell the patient, here's the range of what the lab fee could be. We show the patient the final lab bill so they know what the exact number was. That's how I maintain profitability on implant cases. Because the reality is, if you're going to do these kinds of interdisciplinary cases, you don't want to lose money doing them. You want to have fun doing them and enjoy doing them, and for that to be the case, they need to be profitable. So now let's talk about some really complex cases that might involve 3, 4, 5 therapists, may go on over a year, 2, 3 years of time. And I just kind of want to look at the complexity that goes along with those kinds of patients. So here's our patient. She's missing her 4 incisors. She's got an anterior open bite. She lost the 4 incisors in a traumatic accident. She really wants a normal bite. She wants a pretty smile. And she's very frustrated. She even admits it. She's frustrated with the way her teeth are, so she doesn't do a great job taking care of them. I will also tell you, interestingly enough, she has seen 5 dentists in the last 18 months because she really wants something done. And all 5 of the people she saw in the last 18 months, the only treatment plan they gave her was to actually take out all her teeth and do implants. And she's only 30 years old. She doesn't want to take out all her teeth. So if we really move forward, we notice her lip at rest picture, the incisal edge doesn't look too bad. As we move forward to the full smile picture, again, the incisal, the centrals look pretty good. The biggest problem is her posterior maxilla is actually significantly over-erupted. So we need the entire maxilla either intruded, crown lengthened, or we need a Lefort osteotomy to move it up. So I can come up, as the restorative dentist, I can come up with what I want as a treatment plan. But this is a complex case. This is going to involve ortho. This is going to involve probably orthognathic surgery. Who knows, it may involve some elective endos. Not to mention, she's got a lot of caries that's right down by the tissue. And I'm feeling like we probably even need to do crown lengthening to make sure we get on healthy tooth structure. So in the midst of all that, she also is class 3 skeletally. So if we just intruded the posterior teeth orthodontically by using some mini implants, we end up with a class 3 anterior relationship. So this is a very complex kind of case. And so what I'd like you to think about in these cases, because you have them in your practice, is how in the world do you start having this discussion with a patient? What I know is, because she's been to 5 dentists and they all told her to take her teeth out and do implants, I know she doesn't want that. But now we're talking about potentially crown lengthening, orthognathic surgery, full mouth rehab, potentially the need for the orthodontist to do some alignment issues following the orthognathic surgery. We're talking a lot of treatment. So what I'd like you as a group to do is just have a discussion about when these patients come in your office, kind of where do you go with this discussion? Fees? What do you say to this person about fees? How do you introduce the concept that it could be a really big investment in a way that still gives her the opportunity to say, well, I want to explore it, as opposed to scaring her away at some point. So we're going to stop. I want to have you have that discussion. And then when we come back, I'll share with you what was done for her treatment. And then I'm going to give you some final thoughts about setting fees. So hopefully you'll have an interesting discussion about what do we do and what do we say to this complex patient whose treatment could span several years, to be honest, when we first meet them. So hopefully you'll have a good discussion about it. Welcome back. I'm going to share some thoughts with you about how I open up discussions with patients like this. What I typically say to patients like this one are, you know, I think dentistry can do some really amazing things for you. And I think there's a lot of really good things going on in your mouth because, in fact, she's, other than the gingivitis, she's periodontally healthy as can be. She's got great bone. She's got great roots. Her skeletal relationship isn't great. The condition of the teeth isn't great, but we can deal with all of that. But concerning fees, what I've said for about the last 30 years to complex patients is, here's what I need you to understand. For us to move in this direction, we can definitely do this, but most likely you're looking at the investment of a car. You're going to be putting the cost of a car in your mouth. And honestly, for most patients, when they hear that, if they're still interested, it's crazy, but they all ask the same thing: what kind of car? And that's when I can say to the patient, you know what? I can't tell you what kind of car, but I can tell you it's probably going to be an expensive Mercedes or something like that, but maybe there's some other alternatives. But at least what I know is, if you'd like to find out, here's what we'll have to do for you to find out. I'm going to have you need to see Dr. Kokich, the orthodontist, Dr. Matthews, the periodontist, Dr. West, the oral surgeon, and then I'll meet with all of them. And then after we all meet, we can come up with some proposals for you. But I need you to know before you do all of those meetings, it's going to be a car of some kind. And that's about as specific as I can get, because I don't know what the cost is going to be. I really have no idea what the cost is going to be, because I don't know what those other clinicians are going to come up with. Now, in her case, this is kind of what Vince and Dave and I and my team have always done for 30 years. We basically create a flow sheet. In this case, it also has Roger West in it, who's the oral surgeon. So, new records and exam, we each do them independently. So she sees all of us in our offices independently, including Roger West. Then, ideally, at a study club meeting, we have a treatment planning conference. And we always made sure we left time at our study club meetings, either before or after, for us to have treatment planning conferences. Then, literally, the patient is going to go to each of our offices for our individual presentations, because we each are going to present our fees separately. I do not want to present Dr. Kokich's fees or Dr. Matthews' fees or Dr. West's fees. I don't. So that means this patient's going back to each office to get the fees. In terms of sequencing treatment, I really need access to the teeth and to get past the decay. So if she says yes, the first thing in treatment is actually going to be crown lengthening. So it's going to expose the caries that's there, especially on the mandibular posteriors. I'll then go in and place provisionals. Once my provisionals are on, Vince Kokich is going to place brackets on them. So Roger West has brackets he can use during his orthognathic surgery. Roger will do the LaForte osteotomy, getting it locked in as ideal as possible, and then Vince will complete any orthodontic refinement of tooth position. In the end, she's already said she doesn't want a fixed bridge from canine to canine, so during the completion of ortho, Dave will place a couple implants, and then the case is going to be finished. Probably going to be an 18 to 24-month treatment plan. When I quote fees, I honor my fees for 12 months, and that's what we tell patients. From the day that we quote you the fee, I'll honor it for 12 months. Now, in reality, if she's done in 18 to 24 months, it's not going to be that big a difference in the last 6 to 12 months. So in her particular case, Roger West and Vince Kokich met with me in my office, and they did the model surgery. I explained to them how much I wanted the posterior maxilla tilted up aesthetically. And then we wanted it advanced into a class 1 relationship. We mounted the models on the articulator in that position. We then had the laboratory do a diagnostic wax up with the models in the correct position. And then I had provisional shells made from the diagnostic wax up that I'm actually going to place prior to orthognathic surgery. So now the maxilla was prepped, and using some indices, I was able to seat the shells to match, same on the lower. And as crazy as it looks, she left my office on a Wednesday looking like that with a big anterior open bite. But on Friday or on Thursday, she saw Vince Kokich to get brackets put on my provisionals, and on Friday, Roger West did the surgery. Now, I will just say this for the restorative dentist. Anytime you're doing diagnostic wax-ups and provisionals, I add 40% to whatever my normal fee is. So if your unit fee was $1,000, to do a diagnostic wax-up and a provisional would be an additional $400, because you have to add that extra cost in there, again, to protect your profitability. Patients don't have a problem paying it as long as they understand why it's necessary. So here she was literally leaving my office on Wednesday, and here she is. This happens to be a month or so later, but she literally had the surgery done 2 days later to move the maxilla into the correct position, and then the occlusion was corrected. Vince then did a little refinement to some lower tooth position. During that time, Dave placed some implants, and from left screen to right screens, probably, as I said, 18 to 24 months. But that's sort of how it looks to take a really complex patient and at least introduce the concepts of what treatment can do in a way that's not necessarily scary, but gives them a dose of reality that it's not inexpensive. And I can tell you, this is one of my favorite patients I've ever treated, and she loves the outcome that we all achieved as much as I love doing it. But I know, had I been worried about fees with her, I would never have really given her the option of, hey, this is what we could do. I would have just looked at the teeth and started thinking about how can I manage the caries and all these other things. So for complex patients, you really do want to let the patient have the opportunity to say yes. Use an analogy like a car. So just some final thoughts. I know most dentists would love me to tell them or somebody to tell them what their fees should be. It's a funny thing in dentistry. You talk about fees and everybody goes, well, what should I charge? There's no way to answer that. The reason there's no way to answer that is the cost of living and the cost of overhead is so dramatically varied across the United States. There's just no way to answer that. I can promise you the overhead of a dentist in Manhattan is radically higher than almost any place else in the country per square foot and for staff, et cetera. So whatever their crown fee is, it's going to be way more than what the crown fee is in a lot of other places. You just have to accept there isn't ever going to be a standardized fee. Now, a couple things you can do that are helpful. You can at least evaluate, and the ADA has some good resources for this, you can evaluate what a typical practice like yours, whether it's endo, perio, oral surgery, general practice, what's a typical practice in your community or in your region do in terms of production, overhead, et cetera. And you can also look up, there are places that you can put in your zip code, and it will give you what the range of fees are in your zip code so that you can kind of get a sense of it. That's one way to at least starting to get a number for you. For the restorative dentist, to make it really simple, anytime you use a dental laboratory for something, you pretty much have to charge 4 to 5 times the lab fee to kind of put yourself in a window of acceptable profitability. So if your lab fee for something was $200, you really need to be at least $800 to $1,000, if not more, if you're going to make sure that your profitability stays at least in the 30 to 40% range, which is where I would like to see it for most general practices, more towards the 40%. The ADA says right now the average general practice runs about a 68 to 70% overhead, so about a 30 to 32% profit margin. Now, if you'd like to know what I personally have done over the last 25 years, not initially because I didn't start that way, but what I ended up doing personally is we had target goals. We always had target goals for the practice based on every day. And I had my target goals as the dentist. We knew what hygiene did pretty predictably. And from my target goal as the dentist, I basically could figure out what I needed to produce per hour. And so I knew what my hourly production goals were. Once you kind of have a knowledge of what your hourly production goals are, it helps you with all of these sorts of things like transitional bonding and provisionalization, because you can start to look at how long it actually takes you to do that and then look at it relative to what you really need to be producing per hour for you to reach the level of profitability you'd like. So I'm just going to use a simple model for you to show you kind of how this looks. If you were doing a non-laboratory based procedure and you needed to make $500 an hour, so let's say you're doing a composite, then it's pretty simple. If you can do an MOD composite in 30 minutes or 45 minutes, then you need to be producing $500 an hour. You can figure out from the math where you need to be charging for the composite. Laboratory-based procedures, it gets a little bit different because with lab-based procedures, you really got to factor the lab fee in. So let's just take a simple one. Let's just take 2 gold crowns, and let's say that it takes you 2 hours, both in total, to prep and seat these posterior gold crowns. So you got 2 hours into it, and you need $500 an hour. Simple. You got to get $1,000 for those 2 gold crowns, but there's a lab fee there. And again, just because it's easy math, I'm not telling you what the lab fees are going to be for your labs, but let's just say that you had a lab that charged you $200 for each crown. Well, that means for those 2 gold crowns, you'd have $400 in lab fees. So you need the $1,000 and you got a $400 expenditure to the lab. So that means you have to charge $700 per crown to make $1,400 so you can pay the lab and have your profitability. Now, the reason I do it this way is because on anterior teeth in particular, the lab fees are always higher. And your time is always higher. It takes more time to do anterior teeth by far than posteriors. So let's just do 2 centrals. And I'm being kind of generous because if you have a really picky patient, I'm not sure you can prep the 2 centrals and seat them and get them perfect in 2.5 hours, depending on how demanding your patient is. But if we use our $500 an hour still, and here's our 2 centrals, and we've got 2.5 hours into them, we now need $1,250 for the 2 centrals without the lab fee. And depending on the lab you use, you could easily be $300 or more per unit for a really high-end lab. So now the lab fee is $600, let's say, for those 2 centrals. And suddenly for those 2 centrals, you actually need $925 a crown instead of the $700 you needed on the posterior teeth. And that's why, to me, it's important, and that's why I preferred using an hourly rate and then figuring out lab fees and anterior teeth per posterior teeth. Now, I get it that, in fact, when you're talking about patients that are members of insurance that you're signed up for, you can't do this. So if you're part of a PPO or you're part of whether it's Delta or anybody else, where you're a member, then no, you're not going to be able to do the stuff I'm telling you. But in fact, when you have the opportunity in fee-for-service instances, you really should know what you need to produce per hour, and you really should know that if you want to do anterior teeth in particular, you probably need to be raising your fee over the posteriors. Now, just as a shocking example, if you did those 2 centrals and you only charged $700 just like you did the molars, in fact, you would have brought in $1,400 instead of the $1,850 that you really needed to bring in. And that $1,400 minus the lab fee for the all ceramics, the $600 lab fee, left you with an $800 profit, whereas your $1,850 fee for the 2 centrals minus the $600 left you with a $1,250 profit. But I'll make it a little simpler for you. If you charged for the 2 centrals what you charged for the molar crowns, your hourly production was only $320 an hour. You needed $500. That means your hourly production was down 36%. So this is the sobering part. If your office was running a 65% overhead, but your production was down 36%, you actually did the 2 central crowns for free. That's why it's so important to me that dentists are conscious of what they do regarding fees, and particularly all these little things we don't think about, like I want to use a better lab here. When you have the opportunity, as I said, I get it that a lot of insurance-based patients you can't do it on, but when you have the opportunity, it's really nice to make sure that you are profitable on these kinds of cases. And then just a few final thoughts. Be careful, as I said, about quoting fees for anybody else. I would never want to quote fees for the orthodontist, the surgeon, the endodontist, anybody, because there's too many things I won't see. I won't know that it needs a bone graft that has to heal for 6 months and a soft tissue graft, and I have no idea what they would charge for those things. So I personally never quote anybody else's fees. I would be careful about quoting restorative fees completely until you get the input of every other specialist. And as I said, be careful about implant cases, because that implant not being in the right place, it's going to add to the cost dramatically of the lab fee in particular. Put a time frame on your quoted fees. As I told you, ours is 12 months. So whatever day we quote fees, we've got a 12-month window on there. Prior to placing any case in provisionals, I won't do it unless I get a third of the case fee up front. I learned that in the 1980s when I used to charge a minimal provisional fee, and I'd put people in provisionals and then they wouldn't go forward with anything else. And I ended up with broken provisionals and rotted out decayed teeth. So today for restorative dentists, I don't go anywhere in terms of prepping and provisionalizing until I get a down payment. And then, you know my bias, I just told you, add either a procedural fee or an hourly fee for all of those transitional things that are necessary. Obviously, some of them you can predict. In ortho cases where there's tooth wear, you know if there's going to be an intrusion, you're going to have to do that case. You know on implant cases in the anterior, you're going to have a provisional in those cases. So predict what those fees are in advance. And then kind of to close for the restorative dentist in particular, I would tell you for most complex cases, you probably should plan on your fee being 35 to 40% more than what you think it is in order for you to make sure your profit margin stays up on these cases. Now, on things like veneers and stuff, that's a different story. But when you're talking about cases that go on over a year, year and a half, 2 years, there's just a lot of stuff that comes up in there. And so make sure that you have a fee adequate to compensate yourself for the time and effort that goes into those cases. So it's been my pleasure bringing you this module. I hope I've given you some thoughts about the concept of interdisciplinary cases and setting fees for them, but really about how to communicate fees to the patient, about how to think about fees over a longer term, where in fact you don't lock yourself in so that you allow yourself the ability to charge whatever is appropriate at a current point in time. And then I hope you started to see a model of how my team sets up the way we work with long-term patients, where we literally have that flow sheet. So been a pleasure sharing this with you, and I look forward to seeing you again in another module.
I hope you all have enjoyed this module. Understanding how our individual overhead situations can influence our fees is really fundamental to the financial health of a clinical practice. So that means if you already know your number, if you know the dollars per hour number that you would like to generate in order to meet your practice financial goals, well, that's awesome. You're a little ahead of the game. And if this is the first time you're hearing this concept, well, that means you've got a little work to do when you get back to the office. And in either case, this idea of hourly production goals and the relationship between production goals, office overhead, and our fees, well, that can be the foundation for a very powerful team meeting. So I would encourage you to begin having these conversations with your team back at the office if you aren't already doing that. So what about a dentist who doesn't yet have this level of control in their practice? This could be someone working as an associate or maybe a dentist working in a corporate environment. Does this mean you're off the hook just because you aren't in a position to establish your own fees? No way. Understanding how to become profitable from complex interdisciplinary cases may be just that bit of information that you need in order to begin doing some of these cases, even in your present situation. Okay, as a next step, I'd like to encourage you to follow up this module with the digital courses and team meetings that we've suggested. And again, I want to thank you for your time. I'm looking forward to the next module.